get started. And the first item of business is for Ms. Eisenhower to ensure quorum.
Thank you, Dr. Cooper. And for our court reporter, if we're not already on the record, we can go on the record. Dr. Cooper.
Here.
Dr. Vanderyak.
Here.
Dr. Albert. Bruce Barry. Sharon Chiamento.
Present.
Dr. Conway.
Present.
Dr. Foyer.
Present.
Dr. Kaleo.
Present.
Doug Hexel is excused as he and his wife might be having a baby shortly. Nicole O'Toole.
Present.
Dr. Bombard. Dr. Harris is excused. He emailed me this morning. He is a little bit under the weather, but wishes us well and is probably watching. So hello, Dr. Harris. Chief Pataki. Jason Haig emailed me saying that he would not be here today. And Ben Casper. And we have quorum.
Thank you. So the next item on the agenda is approval of the minutes from our February meeting. I trust you've all had an opportunity to review them. They were distributed via email sometime prior to the meeting, and so I'll ask at this time if there are any additions, deletions, or corrections to the minutes.
There is one correction on page, let me see, I believe it was 112. Somehow Sydney became Skidney, so it was SKDNY instead of FDNY, so it just needs to be changed.
Thank you.
Thank you, Sharon. Any other comments? All right. Well, hearing none, I will ask for a motion to approve the minutes.
I'll make the motion.
Thank you, Sharon. And a second, please. Second. Thank you, Ed Conway. Any discussion? Hearing none, all in favor, please signify by saying aye. Opposed? Carries without dissent. Thank you so much. Okay, the minutes are approved. So the next item on the agenda, of course, is from the very famous and accomplished Amy Eisenhower, our EMS-C program manager, who will report on the status of the program and several items pertaining thereto. Amy.
Thank you, Dr. Cooper. So the first part that I will talk about today is our Always Ready for Children Pediatric Recognition Program. I'm very excited to have been at several events, again, promoting the program. And first I'll share that much thanks to PSWA and PAG, our website has been updated, and I will show you. So we've had the page since last June. However, they have now listed all the hospitals that have joined Always Ready for Children, and these are those so far. So they are listed by county, and as we get more on the screen, you will be able to select by county and see which which hospitals are participating in the program around the state. I also would like to give a big shout out to the Monroe Livingston area, the Finger Lakes RTAC, Lauren Pearson and Adam out there at Strong have been doing great work working with their hospitals in their region and their associated hospitals to get them to join and helping them with the survey and kind of mentoring the other hospitals in their system, which leads me to another really great announcement and partnership. Over the last month or so, the EMS for Children Innovation and Improvement Center has a grant from Toyota, which they are doing pilot programming in Michigan and in Texas right now, having a nurse at the Emergency Nurses Association in those states come into each of their trauma regions to be kind of that mentor, right? And help them with the assessment of their ER, with doing the survey, going through things, finding out where they're at, getting that base level, and then what next steps are based on what's already there and fulfilling the needs that those facilities might need. So very exciting that there was a little bit of money left over. And I like to think that they just love New York, but also I understand I'm the squeaky wheel. And so there's a little bit of money left. And we just got into conversations with New York State ENA for having one, maybe two of our trauma regions have this nurse pediatric emergency care mentor. So that is just in the beginning stages. And much thanks to New York State ENA and Patrick Byrne for partnering with EIIC and our state program to get these resources out there to the trauma regions. And more information will be coming on that. It really is like that brand new. But I went to the ENA conference 2 weeks ago, their state conference. I talked about Always Ready for Children and got a lot of interest from different programs, and they're very excited. So that's great news. We also had a meeting between our group, certain members of our group, and pediatric stack, so certain members of Ped Stack, on promotion and outreach for Always Ready for Children to hospitals and what can be done. And so we had our first meeting, and so kind of getting everybody on the same page, and we're going to continue that work. So more to come on that also in the future. Let's see. So the NASEMSO, I'll go back to this. So the NASEMSO Pediatric Restraint Device Testing Advisory Group, that is, sorry. Okay, so that work is almost complete, at least the advisory part. The final document, I think right now they're having their final meeting. So good luck to them on that. But they have been sending us back the completed documents. Everybody's been kind of leaving comments and edits. So hopefully those documents will be complete shortly to go to SAE to begin their review of it and actually begin building, the potential testing, which is exciting. And NASEMSO continues to work on finding funding for the testing process. So if you guys have any connections, we need a few $1 million. It's not a lot. Next is the EMS for Children Data Center, or the EDC, Pre-Hospital Readiness Project Survey. So this started May 1st. This was released. You may have gotten an email from a constant contact. Please fill out your survey. This will be, you're just going to hear me like this for the next 3 months. So it started May 1st. I believe it goes to July 31st. They did redesign the survey this year a little bit. And here, let me find it, and I'll show you. So as you can see on here, they designed the EMS survey to be more congruent with the hospital survey to really provide an assessment for your agency to look at and see how prepared are you for pediatrics, and then give you that next step of, okay, this is where you're at, this is what you can do next. This is how you can make that flourish. So it's EMS-PedsReady.org. And it does have a lot of components right here just on this page. You can start your assessment, and I'll go through that in a moment. You can also print a copy of the assessment. It's in English and in Spanish if you're more comfortable with Spanish. And there are some links to a FAQ and then pediatricreadiness.org. Also, there's an email to the EDC Center. You can also, of course, email me. So more information all on this page. And at the, down here, resources, there's a toolkit and a checklist. In case you want to read them, you need some extra information, that's there for that. Also, they built this map. So I will say New Jersey, right? New Jersey looks like they're super overachievers that in just a few days. So New Jersey, North Carolina, and one other program were the guinea pigs. They were the beta testers. So New Jersey has 100% because they already did this. So they started in January and ended in the beginning of April. So they were the beta testers just to see how everything went, to kind of fine tune the messaging and information that goes out to the EMS agencies, to all the EMS for Children programs. So that's why some of these numbers are super high, because they were the testing guinea pigs. So that is ongoing. Also on Vital Signs Academy, there is a tutorial for the survey where I went through it. I went through all the questions. A lot of it is similar, right, where we're asking about pediatric education, but it goes into a little more detail. Like, okay, what kind of pediatric education? How are you approaching that? What things are you using, right? Because we don't really have a comprehensive picture of EMS pediatric readiness across the country. And so that's what this is meant to be, to kind of see, okay, where are we at? What resources do we need to build? What resources do we need to offer? So please complete your survey, because it will help the New York State program be able to know what resources our state needs and how we can better serve you. But also it helps the larger EMS-C program know what is needed in the states and what is needed by the agencies. So please do your survey. So Nicole O'Toole, who is our Family Action Network member, we kind of chatted about this. Did anything come up in the FAN meeting specific to this?
No, just other than it was coming out May 1st, and we do have till July 31st to get it done. And they said that the biggest push is from our state reps, so hopefully we can get it out there. And I was going to say, let's try to beat New Jersey, but that's not going to happen, so we'll do our best.
Eric Hicken is persistent, yes, and he has a large office team to help, yes, so. So we also have some additions to our team, speaking of EMS for Children teams. So I would like to introduce Allie Lynch. She's in the back, wave your hand. So this is Allie. We are very lucky to have her. She's really great, and thank God. So she will be handling the pediatric emergency care coordinator for pre-hospital, kind of handling the administration of that, the updates, all of that, helping me with the survey, and kind of making those things happen because I'm all over the place, and other duties as assigned, which she's finding out about. And I'll tell you more about the other duties as assigned in just a few moments. So welcome to Allie. You'll be hearing from her. And, if you can't find me, you can find her, and she'll be happy to help you, or find somebody who can. We also posted for our EMS for Children data position, and those resumes came back. Peter went through them, so we're in the process of planning interviews. So hopefully by our next meeting in September, we will have a EMS for Children data specialist. Peter, what is the actual title?
The actual title is EMS Data Coordinator, and in parentheses, Pediatric.
Thank you. Yes. We changed the name so many times. I'm just like, it's a data person for kids. I don't know the actual official title, but that's what it is. So we're hiring for that. I don't know if Ryan is going to cover this in his report.
I can cover it right now.
Go ahead.
So I'm guessing you didn't yet?
No, I gave some people a pre-warning.
Hi, everybody. So with promotions and new staff members, like I said, we've had a lot of new staff members actually in the Bureau overall. And there's also been different opportunities that have opened up with different grants as well. And so last week we did officially announce that our own Amy Eisenhower is taking a promotion and is going to become the new the Vital Signs Coordinator, which is a public health specialist something, forgive me on the technical title of HRI. So she will be taking on some new responsibilities or a new role within the Bureau. Dr. Cooper, don't worry, she's not drastically leaving quickly. We understand that there's a transition, but we are very excited for her to have this promotional opportunity, and congratulations to you for all the hard work that got you there. So with that, I will add, we have been working on the job description for the new EMS-C coordinator, and we hope to have that posted in the next couple of weeks. So particularly for this committee members and things like that, we would say please keep your eyes open. We'll make sure to share it, obviously, with everyone. But it's an exciting opportunity. And I think it's also the right time to talk a little bit, if it's okay with you, Amy, for what the future of that looks like, too. EMS for Children, for many years, when Martha was here and for the time that the bulk of the time that I've been here, has been a single person. Because the way the EMS-C grant works nationally is every state gets the same amount of money. So whether you're in the middle of Nebraska or you're, no offense to Nebraska, whether you're in Nebraska or New York, whether you have 10 hospitals in total or 200, if you have 50 EMS agencies or 1,000, you get the same amount of money. And so that's been challenging for New York, and we continue to lobby to see if there's anything additional that can come of that, additional funding or things of that nature. But that's also led us with some restrictions in the past that for the most part has led us to only be able to have one person or one full-time person in the EMS for Children program. And that, of course, has its own challenges as well, as when there is transition or change, when Martha, took another opportunity within HRI, or in this situation where Amy's moving up, that it leaves a void and a gap, and one that we would like to, hopefully in the future, try and avoid having that situation. So the future of our grant arm including a number of different grants that we've run through the Bureau, is to be more of a collaborative community approach and a community outreach approach. And so looking at Vital Signs, looking at EMS for Children, looking at many of these different roles and grants, and having a team of people working together as one on several things rather than just one person in a silo working on things. So as transition happens, and there will always be a primary EMS-C person, there will always be a primary Vital Signs person, but there will also be shared knowledge amongst them, as well as resources, as different times of the year tend to have different demands on different programs and different things that are out there. For this time of the year, it's a survey demand. So we're excited about what the future looks like. I will tell you, I can assure you even, you will continue to see Amy's smiling face at a lot of things, and helping us push forward the pediatric initiatives in the state. But hopefully we'll start to see that team grow even further with the data analysts and with our student assistants and a number of different roles that are coming, and seeing a more collaborative approach to it. So we're excited about what the future has to yield. We think it's going to be a number of really good things, and that's probably the big news of the day.
Thank you, Ryan.
I have a few more things too.
Any thoughts on that? Well, I have some thoughts on that. I think Amy has done an extraordinary job in moving this program forward. I think we all acknowledge that. And I do hope that all of us can take a moment and rise and thank Amy for an incredible Thank you. Now, if I know Amy, since she will still be involved in the program, that means that she will continue to do the job that she's been doing, even though she'll have some help doing it. But I do imagine that that's, as Director Greenberg has pointed out, that smiling face will be with us for quite some time. And again, Amy, we're all so grateful. But it's not our gratitude, it's the children of New York State that are the ones who are most grateful for all the work that you've done and will continue to do. So thank you.
Thank you very much. I'm a crier.
We noticed. So continue, please.
Thank you, Doctor. Thank you, everybody. I really appreciate that. I have a few other things, as usual, and so Ryan knows, right, I stalk him around the office, and I'm like, this thing, wait, it's just one small thing, right? So I have a few other things. Some work that we had done in I believe two previous meetings ago, discussing AED defibrillator pad compatibility and use of LifePak 12 and LifePak 15 for BLS agencies, right? Those monitors being only able to be used in manual mode for patients 8 and under. So that was recently approved, like Friday. Let me find it. So we do have, our health advisory was approved. Just going over all of those points that were in the original NASEMSO Pediatric Emergency Care Council advisory. So this is right, highlighting those important things so that people can then refer to that advisory, make sure that they're in compliance, have everything that they need to treat children that might need defibrillation. So all of that is here, and this is in the process of being posted. It will be found, I believe, shortly, because I've been here at the meeting, on your HCS account, and it'll go out to EMS, to hospitals, to all healthcare organizations. Also, I'm going to post it on our website. I'm working with PSWA so that that will be accessible there. And this will also go out to all the listservs for EMS stakeholders that our office has. So that will be coming out, now. As we speak, it's being distributed. So I want to let you know because your work and interest really led to that. So thank you. Another thing that has been kind of a long time in coming, and we had discussed this at a previous meeting, this is part of our EMS-C rural health grant. So we have these kits, the PEC kits that I've been talking about and all the pieces, and well, they're here. And so Allie and many of our student assistants and other help through the office came and we have put together most of them. So each EMS-C PEC, so pre-hospital PEC agency will get one. We're in the process of mailing them and making sure that the list and contacts are correct. So if your agency has had a change to the PEC or change to anything and you're part of the PEC program, please go on our website and update your form so that Allie can update that. We'll have the most recent contact information for your agency. Sadly, each agency only gets one because the money was only so much money. But each will have one, and I'm compiling a list that will go out with them so that you know where these things came from and you can make as many more as you need if that's what you like to do. So they come in a dry bag, and there's a lot of stuff in here. Oh, and I think something that you guys haven't seen already. All right, we'll get to the rest of that. So we also have been working on that pediatric agitation document. So this is also posted on our website, so you can get this right now on the EMS-C website. Much thanks to everybody who contributed to this program and this project and all your hard work. So now we have a New York State one. It's very cute. So go online and grab it. Also, our updated PAT document that you guys have been working on, and much thanks to Sharon for doing all the editing, because that really helped, because otherwise I would have been like, I don't know. Like, just fix it. So this is up to date, and I mean released 2 months ago. So if you have not gotten a new PAT document in the last 2 months, it's online, but you can also go onto our website, fill out the order form, and you can order either of these documents or the Badge Buddies, and Allison and I are working on getting them out. So you'll get one of each of these in the kit. You will also get badge buddies for your agency in the kit. You'll get 25. So if you need more than that, you have to email us. There's also medical communication cards. So much thanks to all the other EMS for Children programs. So we do a lot of work here, but other states also benefit from that. So these documents I share with other state programs. These badge buddies I share with other state programs so that we're not all recreating the wheel. Because just like for a long time there's only been one of me, in many other states there's only one of them. And so when we all create something, we share it with each other so that other states get the benefit. So these were, I believe we got these from Florida, and they got them from Michigan, and they got them from Kansas, and so we're all kind of on the same page. So inside, I don't know if you can see, right, it has a picture, it has words, it's in English and Spanish, but there's great resources in here, and I believe that these are also going to be put on Muru as an accessory. So yes, Steve just nodded yes, these are also available on Muru. Yeah. Great, so he says they're already on there. So if you're using the Muru app, you can also access these on Muru. On the back, there is a place where you can write. It's small, but it's something, and there's a dry erase marker in here too, so you can wipe it off when you're done with that patient. You also get a pedia tape. So it's a Broslo tape, but a pedia tape, that brand. You get a PD wheel, so dosing for children. You get a hand heavy tape. If you use hand heavy, you can use that with their system. And then we also have some stim toys because not just neurodivergent kids need a little something, or people, right? Because this doesn't have to be for, just children. But if you're scared and you're in an ambulance and you're a little kid, right? Fiddling with something helps. So these are all rubber. You only get 4, so you might have to replace these in time because you're not going to get it back. But these little men, they stick to stuff, right, which is kind of neat. And then, of course, the little poppers that if you have children, these are all over your house also. So you get all of that in a dry bag to keep all of this stuff safe. And so over the next several weeks, we'll be mailing them out to PEC agencies that are already signed up, but we also have many, many, many for all of you who are going to want to sign up so you can get cool stuff like this and get our monthly update and all the other things that the PEC agencies get. And then my last thing, so because the federal government was working on their budget and they went a little bit over, as happens every year, the EMS-C funding from HRSA, we got part of our funding. I'm still awaiting a final notice for when the rest of the money's coming. So just so that you're aware, we have funding, but it's held up in the process. And I believe that's everything for me unless people have questions.
Questions? All right, well then hearing none. I think it's time to hear from Nicole O'Toole about the EMS for Children Family Action Network. Nicole?
Thank you, Dr. Cooper. I think Amy pretty much covered everything in my report from HRSA. The committee met on March 20th, and it's still all held up. And then also about the May 1st, the assessments that came out. The only other thing I have is EMS Week is coming up, May 19th to the 25th, with May 22nd being EMS for Children Day. So it's also the 40th anniversary of EMS for Children Day. So very exciting. And if anybody wants to download some promotional material, you can go on the EIIC website. They have a lot of free things. So that's it for my report.
Questions for Nicole? All right, hearing none. It is time for Director Ryan to give us the latest and greatest. Thank you.
I'm going to keep it brief because Amy took so much time, but I think that's a good thing. I'm okay with that. So I think the big things just for this group to be aware of is, we did make it into the budget this year from a proposed, both funding and legislative changes. Unfortunately, at the end, none of the EMS portions remained, so they came out. But it really fostered some great conversations, some really good things moving forward. And there's a number of bills that are continuing or that are up in the Senate right now and the House. So we're still waiting to see what happens in the remainder of the legislative session. We know last year a portion of EMS things made it in through during the budgetary process, and then another portion of things made it in through the legislative process with the House and with the Assembly and the Senate. So we're excited to see where this yields and where it goes to. We had a lot of good progress last year, too. We have the System and Agency Performance Standards Program that was created. We had the task force initiatives that were created. So a number of things, and there's a lot going on and moving in a really positive direction for EMS in many different ways. So we'll, kind of wait and see where that brings us. But a lot on our table and a lot of things moving in a good direction. There's also some regulatory changes going on right now on the EMS side. So the education regs are completed. They've finished the public comment period. They'll be coming out or going to SEMSCO for the final approval and adoption. So that will probably happen next 4 to 6 weeks. It will happen this week for the final approval, and then if it goes through, it will happen next 4 to 6 weeks. But we also have several other regulatory packet changes that are changing, some that affect this committee as well, including equipment standards. And the new equipment standards have different things because of Amy that focus on pediatric care and making sure that we're prepared to treat those pediatric patients. There's another one for blood regulations, community paramedicine coming down the pipe, and I'm leaving one out. I apologize, but so there's a number of different things happening on regulatory changes as well. So we're seeing a lot of really strong and good movement. Oh, the System and Agency Performance Standards regulations. That was the other one. Thank you. So a lot of really good things moving in that front. The Bureau is been really happy, can't complain on being able to get new staff, including a number of student assistants who've been phenomenal additions to our team, and being able to help with particularly some special projects that aren't always regulatory in nature, but more grant funds or things of that nature, and give us a little bit more bandwidth and opportunity to run reports or do statistical analysis on things that otherwise might have to sit on a back burner. So we're excited to see those movements moving forward as well. So that's everything that I think I got for right now, and pass it back to you.
Sure. One question. This will probably come up at CMAC a little bit later this week, but I wondered if you could enlighten our committee about the status of the hiring of a medical director for the Bureau.
Yeah, so we've gone back and forth. We did go through one round of what was going to be a contracted medical director. It did not yield the subject matter expertise, I believe, that the department was looking to hire. And so we are moving forward on a permanent position, and I think you'll see that in this fiscal year.
Would that be a full-time position or part-time?
It looks like it's going to be a full-time position.
Wonderful.
Yeah.
Okay.
Wonderful in some ways and challenging in others, because sometimes full-time opportunities is not.
Yes, understood.
Yes.
I think I can express the wishes of the committee that the individual who the department ultimately selects have a significant background in pediatrics, so that that individual can work with us and ensure that we can continue to provide the best for the kids throughout New York State. Thank you.
Wholeheartedly agree.
Okay, I think we're up to some old business at this particular point. And the first item of old business to cover is the Monroe-Livingston Regional EMS Region's hands-heavy implementation project. And we're lucky to have Dr. Maya Dorsett here with us today, who has been leading the charge. Maya, please take it away.
So red is on. That's good system design. All right, I'm very excited to be here, and I'm going to start off by acknowledging that this is not a project that I have done remotely alone. It's taken a lot of work, and it would not be possible without Amy Eisenhower, who was able to help us with this. So what we took on was the challenge of reducing pediatric medication error and improving peds medication safety. And we knew that this was likely a large problem within our region, just like it was in every single EMS system that had ever been examined. And one of the things that we were looking for were potential solutions, because even though that the problem had been described that anywhere in the literature, approximately 50 to 70% of the time, pediatric medications, including critical pediatric meds, were dosed correctly, which is like flipping a coin and hoping that you get the right dose for a child. There hadn't been a lot of publications showing how to get it right. There was a lot describing the problem, but not a lot about solutions to the problem. And in 2020, an AMSP published a position statement on best practices for pediatric medication safety in EMS. And the most useful part of this document was the resource document, which was a systematic review of the literature about what really are the evidence-based best practices of how to do this right. And this included a lot of best practices, including getting weights in kilograms and using validated things like length-based tape, which came with its own set of errors to improve weight estimation. But one of the key things was that there was publications, including one by Rappaport et al. In Denver Health, saying that one of the key innovations was using a volume-based dosing method, so that essentially the elimination of math in the real time of taking care of sick children who are medication dosing to get it right. And so at the time, I had developed a lot of interest. The Rappaport et al. Had used the hand-heavy system, not currently the app, but at the time it was done, it was sort of paper cards within their system to implement volume-based dosing. And so this was the thing that I had wanted to implement, because I wanted a solution that had this particular feature. Not just like we're getting weights on kids, not just opportunities to practice, which are all really important, and we'll talk about how we incorporated that into our implementation, but something that took the math out of it. And I was significantly more motivated to do this when we implemented a medication cross-check regional medication safety initiative in our system. And Sharon actually works with the agency where I'm a medical director. And I just happened to pick a scenario of a 5-year-old with a seizure as our scenario to practice a medication cross-check. And the difficulty and the time lag in coming up with the correct dose of midazolam for this simulated seizure patient while I was just standing there, right? Like it was a mannequin. There was no seizing child, no crying parent, none of this in that circumstance. It took forever for a bunch of the paramedics and the Broslo tape was outdated and it had diazepam in it. And so like I fixed all those things, but I need to have a system to help people take care of children in this circumstance and actually improve safety. So the hand-heavy system was one of the few that does that. So this is what it looks like. This is a screenshot of the app, and I'm happy to show anybody what it looks like. There's length-based tapes that go along with it, but there's also, you can just use patient age. So like when you get dispatched to a 6-month-old seizure, you can actually just like click on that, and they show that you're actually pretty close to the correct, unless the kid has some other reason that they're going to be smaller than normal or larger than normal. And then it can take you through, you have the list of medications, and the key component of it is that it has what is the concentration of the medication and the volume to be administered. So you can click on that and it'll pull it up. And even more importantly is you can link it directly to your protocol. So if I'm dispatched to a seizure, I can search a protocol, and it will automatically, it's integrated into the protocols, pull up the protocol, but pull up all medications, the correct dose for that weight child, as part of the application. So you can't see this, but it's in the report that was handed, is we really felt that it's never just the tool, it's always about how you implement the tool. And so we thought this had to be coupled with education, integration into normal practice. We had to get this right, including knowing the concentrations of the medications in our field. So the first thing we did actually, because we were doing a regional implementation, so to describe our system, we have 12 ALS agencies, a couple ALS FRs. This was initially an ALS implementation. We've brought on some BLS agencies as well.
Just going to pause you for 1 second. I know that's really far away. Anybody who would like to follow along, we both shared the PowerPoint and the web broadcast is also shows live what's up there. So if anybody can't see it or wants to see it, they can pull it up on their computer.
Okay. So what we did is we did a survey of every single agency in our region that had every medication in the protocol, and they had to tell us what concentration med they carried. And we found, much to our surprise actually, is that there was only one medication with a variable concentration amongst all the different agencies, which made our job a little bit easier because we all know medication shortages have made medication variation and concentration. And using a volume-based dosing application, that's very dangerous, right? Because if I can create errors by doing that. So the only medication with variation in dosing was ketamine, where some carried 50 mg per mil and some carried 100 mg per mil. And so I can show you on our application, that's highlighted in red so that there's integration into the app of highlight of variable concentration. We have both listed. Then we wrote a regional policy that we kept in our back pocket that wasn't a stick up front, but we wrote a clinical guideline for safe pediatric practices and made that a regional policy passed by our REMAC of these agencies operating within our region needed to comply with that. And we basically took the position statement from NAMSP, the evidence-based guideline, and made that a regional policy, and then built the app with everything integrated into the protocol, and then built an education system with tabletop exercises that included 5 separate cases. 3 were pediatric. One was an infant cardiac arrest, like a 1-year-old seizure, a 5-year-old pain management scenario, but then also 2 adult cases so that people would actually go to the app and use this on a more regular basis, which was a Levophed drip calculation for a septic shock patient and ketamine for pain in an adult because we had a misdosing problem. And the goal was that all agencies would implement this. It actually only took like an hour and a half to do it. We did it as part of like our regular quarterly training at my agency. Not all agencies implemented it that way, but the majority, like over 80% of the people who got access to the app ended up doing that education. And then we piloted it with a small group. But this is like an example of what the tabletop exercise would look like, is they'd have a scenario, basic vital signs, and a series of tasks, coupled with the psychomotor skill of actually drawing up the medication using simulated medications and doing a medication cross-check with a partner. And it didn't take like a whole lot of time to do, but I think people found it very beneficial. We don't have just one agency. We have a bunch of different agencies with different structures, large private agencies, smaller agencies, BLSFRs. What this graph shows essentially is the timeline of how we built users up. So in the orange we have about 350 paramedics within our region. So it was around July or August where we had the majority of ALS providers in our region registered as users of the app. So from the perspective of the app administrator, I have a list of every user of the app that I can access. When did they get access to the app and when was the last time they used it? The little tick up in the middle, that is the last time they accessed the app. So this was polled, I have more up-to-date data, but this was polled like a week into February. So a week into February, 175 of the 452 users had accessed the app within February. So there are some people who got access early on and are not integrated into their clinical practice, but somewhere around like 30 to 40% are accessing it every single week, and I know that because I can see when was the last time they actually pulled up the application. So we have variable usage within the group. Medication error is a hard thing to pull system data on because the definition of what defines an error is a little bit different for every medication. In the published literature, it always says like 80 to 120% of the calculated dose is a correct dose, but it's a little bit different when, for example, I'm looking at fentanyl and the protocol range is 1 to 1.5 mics per kilo, and I'd say 120% of 1.5 mics per kilo seems a little more clinically significant than like 20% over on some other medications. And some medications top out, right? Like dexamethasone tops out very easily at like 10 milligrams. Same thing with epinephrine. So it's in the report. This is the table where I used to define what those were. And thanks to Peter Brody, who wrote a report using the image trend data bridge, we were able to pull regional data for every child 13 and under who was transported to Monroe County Hospital and every single one of these medications on the list. Because we have, like many regions, 3 different EPCRs. We don't have medical directions. So this is how we did it and how the rules of how I process the data. And one of the things we wondered is, like, if we're using the weight that's documented in the PCR, is that going to be accurate? And luckily, I have pediatric emergency medicine fellows who needed quality improvement projects, and I gave them essentially a year of data of 13 and under children transported to Strong Memorial Hospital who got medications, and they looked to see what was the weight documented in the EMS chart, what was the date on that visit in the emergency department, and greater than 90% of the time that weight is exactly the same. So I think they're actually writing down the weight when they bring the patient to the ED, but for us, for calculating the metric, I think we're very confident when we say there's an error or not an error, that our weight denominator is correct. All right, so this is a control chart, and I can tell you in the updated data, it continues to improve. So what is plotted here is essentially 4 years on a monthly, nearly 30-day basis of what is the percent correct dose. So 100% would be 100% correct dosing, and then below that, and I can't even see, but it was like 70% for years. You can see how much variability we had early on. A lot of that is because we didn't have that many meds administered to children, but you can see that the denominator, as the control limits go narrow, we actually have bigger numbers, like more kids are getting things like pain management, which is a good thing. But prior to implementation, only 70% of the time were we dosing children correctly by the definitions. And since implementation, 83, now 85% of the time on the most recent data, we are dosing children correctly. Right, so that's a 15% improvement. The interesting thing is, not all medications, I think this is sort of like not as important for all coming meds as it is for specific critical medications. So for example, 90% of the time we were dosing dexamethasone correctly. That's because it's hard to get it wrong. Because once the kid hits 2, the dose is probably 10 milligrams, right? And that's what you give. And a lot of the fentanyl was actually like underdosing, not overdosing of fentanyl, which is not great to undertreat pain, but much less concerning than like a 2 to 3-fold overdose of fentanyl. So one of the most commonly misdosed medications, which I did find quite disturbing, was midazolam for seizure, which prior to implementation, we only got correct 60% of the time, right? And luckily, we're changing the dosing to more evidence-based dosing, but 60% of the time. So this is only 2 quarters, but what I want to show you is this graph. So what this graph is, this is called an X chart, which is individual administrations of midazolam over time from 2020 through to the end. And what is plotted here is the dose that the child received divided by the correct dose. So but your goal is that it's a 1. If it's a 1, it's essentially like a perfect administration. You can see how much variability we had, and then you can see that the line narrows, and see all those little dots along 1? Those are all correct doses. There's one outlier, and the one outlier is somebody I can look, and they were not a registered user of the app at the time. So I contacted their agency. I made sure they got access and trained on the app. I now have 3 months more of data. We've only had 2 subsequent dosing errors, both from people who never got onboarded to use the application. So for users of the application, we have had 0 medication errors for midazolam dosing procedure. The test really will be, we're rolling out the protocol updates where we increase the dose. If you think about what is the work to change everybody's knowledge of what is the dose of midazolam versus flipping a switch and making it sure that everybody's app shows the correct dose, which is now gonna be 0.2, that'll be a real test of like, can we rapidly push out changes? So those are all numbers, and I love numbers. I do quality improvement, like control charts feed my soul. But I think, to me, I get like emotional, right? Like these are I get this kind of text messages like from providers all the time, and then I get ones like this, right? Like I had to take care of a pediatric cardiac arrest this morning. Like I felt more prepared to take care of a sick child. It was a cognitive offload. We have a lot of barriers to improve, and in that report, I left the free text comments on people's perception of components of the app, about app use in their clinical care, because I think that the way we make positive change is we hear from the people who are the end users. One of the things that we were asked for, and we got from Hand Heavy, because they were implementing it, is that there was only 2 weights for adults, which was really inconvenient. We now have the full spectrum of adult weights, including for ideal body weights, dosed according to height, and those are all linked to the protocols. We're working into integration into the EPCR directly, because we've had a few documentation errors that are like documented the ml instead of milligram, which is a big problem when you're talking about epinephrine, but I can actually go down and drill down into the EPCR and see what was documented and speak with the providers. And then the last component is improving the frequency and quality of pediatric care education opportunities. I don't think that this would have been successful without hands-on education on how to use this and have people, like, when we did that, I realized a bunch of people didn't know how to use a stopcock for dosing of pediatric epinephrine in the course of a cardiac arrest. We need to integrate those. So doing the checklist, one of the things that we're doing regionally, because of the readiness checklist, is and I think this created the model for it, was how do we as a region, as a program agency, make it easier for agencies to be pediatric prepared? Because I think thinking that every single agency that has a limit of bandwidth, limit of people trying to create these opportunities, is going to be successful in completing every element of this gap analysis is not really sort of realistic about the barriers that people experience every day. And the Hand Heavy project showed us that as a region, we can actually come together and solve something by creating a system where it's easier to do the right thing, right? Like if they have an issue or suggestion, there's one email they send it to, me or our other administrator take care of it, follow up on those requests. I'm finding errors that agencies didn't know about because I'm looking at regional data, and every time I find a clinically significant error every quarter, when I look at the data, I email that agency and let them know so that they can look into it. And so we've created a Pediatric Advisory Council as a subcommittee of our REMAC. And one of the things that we're going to do is not only continue the work on quality control here, because we still have opportunities, but also think about how do we create those continuing education opportunities that are going to support safe pediatric medication dosing as well as care of critically ill children. Sorry. Thanks. That's it. Lots of people to thank.
Thank you so much. That's incredibly thorough report and phenomenal work. And if a program like this could be, exported statewide, I think we could substantially reduce the rate of, of medication errors in children. I see Amy giving me the eye here, because of course that would be quite an enormous undertaking. But at the same time, it's a necessary undertaking to make sure that kids are being properly dosed, when medications are utilized. And of course, I also can't help but comment that, this is, the first time we've heard from Maya Dorset, and that was just amazing. And we hope that you become part of our family here and going forward, and your future participation in EMS-C will be, I'm sure, welcomed with open arms by all concerned. So that was just a great presentation and a great job, and thanks for your diligence in carrying this through. Not easy. Questions for Dr. Dorsett? Dr. Van Diat? Of course. It's our microphone.
First of all, I think this is a great project that you've embarked on, in my backyard, incidentally, okay, and it's absolutely wonderful. And I think that the examples of seizure management, I think, is especially noteworthy. Over the last 10 years, we've really, maybe even 5 years, we've recognized the importance of rapid response to seizures. It used to be when I was in training, it was like, okay, give them 30 minutes, then you call it status epilepticus, and then you have another half hour. Now it's recognize it within 5 minutes, get it under control within 10 to 15 minutes, and do it that way. And so the midazolam intranasally, which is I presume you're talking about, is critical, and of course the dose has to be right. So if somebody is really, having a problem with figuring out what the dose is, that is a really important thing. So that example especially, I think, in my mind, knowing how important it is to treat seizures and how often these occur in children, I think is especially important in terms of rolling something this out statewide. So I think you've done the pilot project, which is absolutely wonderful in a relatively controlled setting. But I have a couple questions also. One of it is, of course, and you alluded to this, is the importance of that the concentrations of drugs are the same. Because if the concentrations vary, then the volume-based dosing is a problem, right? That's number one. And then the second is a question that has to do more with in rural areas where you may not have the ability of, there's no Wi-Fi, you don't have internet, you can't do it because of some of the barriers geographically. Will that affect your app and these dosing, and what then becomes a substitute, and how would you be handling that?
So to the first question, that is the biggest issue. And so whatever system you have, it's never like a set it and forget it. There has to be like education and vigilance for monitoring the correct dose. One of the things that we did in our system is though the BLS providers didn't have access yet because of the number of licenses we had. We had, like over 1,000 BLS providers and 350 ALS providers and 500 licenses. So we now have BLS providers on board, but we incorporated it as part of our medication cross-check. And we have a regional email that's just like handheavy@milrems.org that is sent to me, it's sent to Ben Sensabaugh, sent to Shane O'Donnell, so that one of us can identify or respond and immediately send out a message if there's anything wrong with concentration dosing. We haven't had to come up with that yet, but there's mechanisms that we can immediately let people know about that. With regard to timing of medication, we saw an increased percentage of IM-IN dosing of midazolam, which was promising. And one of the things I was hoping to see was a decrease in time to midazolam administration, because that's actually one of the FAIR measures, like the Florida quality measures. They haven't been incorporated nationally into NEMSQA, but to me that was an important measure, is looking at time of administration of time to administering time-critical meds. The issue is that the only thing I can pull is what was your on-scene time and what was your med administration time. And so if the kid re-seized, right, that could look like a 30-minute, and I can't pull that out. With regard to the rural question, I haven't tried to access the app without access to, I think it will just pull up the most recent, and so it wouldn't necessarily do an update, which is one of the dangers. I think I
can answer that one.
Oh, okay. So
the way the app is designed.
Can you identify yourself?
Ben Sensenbach, Monroe Livingston Program Agency. Which button? Which button?
Oh, why don't you just sit next to me?
There you go.
You want to sit next to me?
Which button, guys?
The Siri.
Thank you. Ben Sensenbach, Monroe Livingston Program Agency. So the way the app is designed is all of those updates, all of those protocols, all of those concentrations are initially loaded. So when somebody installs that app, it's loaded and ready to go. It periodically updates, and it forces the user to update when those updates are available. So as soon as they open the app, it's going to queue them up to download those. If they are remote, So like when I was on the helicopter the other day and there's no cell service, I can still use the application. The only thing I wouldn't be able to do is just that upload directly to my charting platform.
So it doesn't have to.
No, it's a great safety
Doesn't
net.
have to be online, you
Correct.
just have to have it on your phone.
Correct.
Thank you.
I mean, people do need to use it regularly to get the updates, though. And so one of the benefits, like when I'm done here, I'm going to be sending an email because we have all the protocol updates, is we've never had a list of all our providers in the region of an email list that I can directly send messages to. But now, because I have all their emails as the registered users of the app, I can directly message every single user by email. So when we have updates or education or their data, which I share right with them because it's their data, I message the users of the app directly through an email. And so I'm going to send them a message saying, like, you really need to, if you haven't opened it recently, you really need to open it because we've updated a bunch of the protocols and concentrations. And because I have to figure out, as I do the data analysis, what is their drop dead date for the dosing, the midazolam dosing change, so that I can account for that. But to me, I think that's going to be a very important test of how can we like rapidly disseminate a protocol change and concentrate, for that, because it's going to double.
So one more question about this is, this has to do more with the state rollout. Are you at a position at this point in time where another region in the state could also trial this? Whether it's in Buffalo or Syracuse or downstate in New York City. Because the only way to do it, it seems to me, is this is one region, that is very successful, and you obviously have a lot of energy around this. But then if it goes to another area, that might be another opportunity for seeing whether this similar use of the app would work there also. I don't know what the potential for that is, but it seems to me that that might be one of the steps if we're thinking about maybe rolling it out further than just Monroe-Livingston County area.
The big barrier there is cost. There's no lie, this app is expensive. And so what we've done now is, we had a certain amount of grant funding, thank you to all of you, to do the initial rollout. We had to go through, it's much cheaper if we continue it as a region, and so we got our Monroe County Chiefs Association to actually come together, because I did a little negotiation and got some, like a regional implementation for hand-heavy, which I want anyway. Because I want to be able to control the updates and the administration, because we have people that we know are going to do it in like a timely manner and pay attention to all those things, because we have stability at the regional level that we don't have at an individual agency level, and we have prorated costs for each individual agency who are coming together to fund this continually. But it's going to cost us a fair amount of money in the region. There was a lot of barriers until I, I put it in the perspective of like number of IOs per year versus the cost of a tenfold med error, and also the regional policy that we have. Like, you have to find a way to meet the regional policy. You can come up with your own way, or you can use this particular way. I think cost would be the greatest barrier. The time is tough, and getting individual agencies to find a way to do the training and the rollout and everything else, like, it was not all like hugs and roses, like the whole way to get everybody to implement it. But I think that's all doable, like with regional perspectives. I think cost is a problem.
Thank you.
Sorry to roll over the time.
Mike McAvoy, please.
So you're probably aware that there's research going on in peds now looking at age-based dosing versus weight-based dosing. And would this be able to accommodate that if that pans out?
Yes, because there's both length-based and estimated weight, so you can just click a different weight. One of the things they don't have, so I think they'd have the ability to do it, because on the adult side, on one side it has kilograms, the other side has pounds. So it has kilograms in the middle, pounds, and then height on the left, so I can quickly say how many pounds are you and pick the correct weight in kilograms. I think they'd have the capability to do that specifically for like children if it came to that. Like if you wanted to use like stated parent age or length-based tape. But length-based tape, in all the critical children we've had, the providers used the length-based tape. And we did even like little PDSAs, like in my own agency, I gave the length-based tape to different people and said, where are you gonna actually use this? And so every agencies, I gave people to pilot like when it's gonna be. So like the hand heavy tape is small. It's actually with our pediatric blood pressure cuff in our monitor because it's a pediatric vital sign. And so I trained the BLS providers to think of it as a pediatric vital sign because they're the ones that are doing it and they all trained. But the key is like, I'm already thinking, how do I keep that? Because it's gonna fade, right? If that's just the training component.
Other questions?
I'd be interested to see the research on the age-based one, only from the point of view of my son's in like the 98th percentile on the weight category, and his best friend is in like the 5th percentile. So when you put them next to each other, it's a great comedy show for a multitude of reasons, but including size. So it'd be interesting to see.
So that research is actually ongoing through PCARN, so EMS for Children is funding it. And Buffalo, AMR Buffalo is one of the 20 nodes across the country. So Dr. Clemency has taken over that work from Dr. Brooke Lerner, and Dr. Peter Diane is still participating. And so it is, I was actually gonna bring that up because it is related to midazolam and this issue of incorrect dosing. So they're looking at it from a different perspective of if we change it from weight-based to age-based in children, what does that look like and what is it like? Will it significantly help or is it not going to help at all? So that is still ongoing through PCARN. And I did have one question, and you kind of mentioned some of that. In your presentation, you mentioned some of those errors were related to new people not being onboarded. So in the future, what's your plan to address that?
So that was actually old people who hadn't been onboarded because we're still catching people who like slip through the cracks. So our plan going forward, right, is I would say we're still in the quality improvement, but we're also a little bit in the quality control phase. So I'm the medical director of the paramedic program at MCC, also conveniently, who produces most of the paramedics who work in our region. So it's already integrated into the program. Students get access to the app at the beginning. They are the most facile users of the app we have probably in the region because they integrate it into like the scenarios they do, everything else. Individual agencies have been encouraging them to include it as part of their onboarding. Some agencies for sure have. Others have not, and so I have to continue to work on that. And as leadership changes at individual agencies, I have to remind them that this should be part of their onboarding process. It's always going to be a quality control phase. Like I know that every 3 months, I'm going to be sitting down on a Friday night. Ben's going to send me a pulled report, and I'm going to be working on the data and finding every med error in our system so that I can continue to monitor those things. Because I'm never, like if you take your eye off the ball, I can create the system. There's always going to be some degree of drift until it becomes like an automatic way that people approach this problem. But it's the newbies into the system are not the ones that we need to convince to use an app. It's people, I think if you read those comments, there are people who think it's unprofessional to pull out your phone in the context, who think we just need to be better at teaching paramedics to do math. But I think I can't do math with a seizing baby. And I think I'm pretty good at math when I don't have a seizing baby in front of me. So, trying to create that system.
So, and kind of as a follow-up to that, obviously, and we talked about the cost of the app and those barriers and things. There are other apps out there. Do you think that this could be achieved with other tools, but the priority being having an invested medical director, having agencies that are invested, having the education component, and then not just setting it and forgetting it, like I think sometimes we do in EMS? Yeah,
I think this can be achieved with any tool that has the best those best practices. Like, that's why I think that paper, like, outlines, like, what are the elements, and then you have to think about how do people integrate this tool. The problem with most of what we create for pediatrics is we act like it's special for pediatrics, and then nobody pulls it out until they have a sick kid, and the last time they pulled it out was their training 2 years ago, and they don't remember how to use it. Like, just think about, like, the straps on a pediatric transport device, right? Like, we have to integrate that, and I think that's one of the great things about the Pre-Hospital Pediatric Readiness Project. It's making you ask, like, when was the last time we did pediatric training? Are we doing it regular? I think the solution has to be something that people use every single day for adults, that they then know how to use for a child, right? Like, if it's something absolutely special, they're not going to feel, it's going to be foreign and weird and cognitively overloading in the context of the situation of where all those things are possible. So it can be literally like note cards, as long as those note cards are used regularly for adult medications, right? Like, and that you're updating them accordingly. It could be another app, but I think it needs to be like math free is the solution.
Hi, thanks for the outstanding presentation. And when I first heard volumetric dosing, of course, my brain went to kind of quality projects in AAP looking at going away from volumetric dosing, but you sold me for this group. My question is, have you thought ahead to that, doing the right thing pre-hospital, but then you get to the hospital and that handoff? How is that volumetric dosing going to be handed off accurately to the new providers, especially when hospitals may have different concentrations of drugs that are on the truck, et cetera?
Excellent question. So the app, when you click on the medication, what shows up is the volume, but you also have the correct milligrams. So you can actually pull up the patient report, and what it gives you, it is, if I pull up the patient data from my phone, it doesn't give me the ml, it gives me the milligrams or grams or whatever that I administered. So it shows me, like, when I pull it up, the actual dose, not the ml administered.
So in that handoff, before, like the printed stuff that comes down the line afterwards, someone would be able to bring up their dosing on the app and show that to a provider in the handoff?
Yes, and even for like a cardiac arrest, there's a cardiac arrest component of the app that has like a metronome, ventilation, so we have a default set to 15:2, right, because kids are like different than what we're used to doing. Every time you click on that, it creates a patient record. One of the things we're working on with some barriers from some of the PCRs who want to charge us more money to do the right thing is direct integration into the app. So like when the provider is done with their chart, it automatically, they can import that data with the times of administration as well as the correct dosing directly into their chart. There's integrations with image trend, EMS charts. ESO is a bit of a different integration. The hard part for us is that we're a region, not an individual agency, which creates its own special circumstances and difficulties. My dream is someday we just have HL7, right? And the data flows to the hospital and everything is integrated, right? And what appears is I want to know what that kid got. I just like pull it up and it's one seamless thing where I can see exactly what it is that was sort of clicked in the context of the app. That doesn't exist today, but it doesn't mean it's not, like the technology exists to make that happen. But for now, you can definitely pull up you can review within your chart and show that. And that's actually something that I think we have to be, once you roll something out, you realize all the things that you would have changed. I think how we integrate some of that into our handoff and how they can see the milligrams, not the mLs. That was a deficiency in our education that as we roll out some of this other stuff is something that we need to work on. Simply from the commentary we got where they're like, it only shows the ml. I'm like, no, it definitely shows you the milligrams, but they weren't sort of clicking on the thing and pulling it up.
Yeah, I definitely like that you eliminate math from the equation because a lot of people just really don't. It's very awkward looking one way and talking the other. Taking math out of the equation because a lot of people, they just don't get it right simply. And when you're in moments of high stress, you're not necessarily going to be, able to necessarily function that way. So I really like that. I know that you mentioned as well that there was what's all volume, or it has the option for volume-based dosing based on common concentrations. I know one thing that is in like the hospital-based system, where at least I'm a part of, it's similar where it pulls up, you can flip a binder to the appropriate weight. It gives all of the appropriate, or all the, ACL or PALS medications that you might be administering, and it gives you the volumes of each of those. And actually, I have a PDF of all of those. One of the worries that I have is like too many apps. Because it would be nice to have a one-stop shop. And I noticed that I just pulled up like the Mover app, and I was like, okay, I wanted the dose calculator. And if you put in a particular dose, but then you flop to a protocol, it doesn't do the math for you, and it usually kind of defaults to like adult dosing system. So that could be confusing with our current setup. But to have something where it can be integrated into a pre-existing app, and the Mover app is a lot better than previous protocols that have existed. But it would just be really nice to have a one-stop shop to be able to kind of accomplish all those goals. And I think it's great how you've reduced the medication administration errors by 15%.
Yeah. So the app, the protocols are in the app. So in our region, it serves as the protocol app.
Gotcha. So it would basically just go and it's in place of Muru.
In our region, it's used in that way because we've integrated the drug dosing. Yep.
Nice. And is there a hard stop too, so you can't supersede an adult dose? Did you embed all those? Okay, yeah.
Yeah. So
I know that could be.
In the setup, we created the entire setup, and then we reviewed with a committee. We all played around with the apps and made sure that we found a bunch of errors. Then we identified a group of clinicians to try and break all the things and find all the errors. And so we piloted it with a small group who found all the things. And whenever somebody brings up anything confusing, they message us immediately and we fix it. The reason the app is expensive is because there's 24/7 support, and they will fix any error that you identify, usually within about 12 hours.
No, that's excellent. The other thing that, you've admitted that you like statistics and quality-metric kind of initiatives. It's like for determining the actual weight of a child. Me as a person, they make 8-year-olds many different sizes nowadays. I don't know what they feed them, and they also do math differently with Common Core. But when we go ahead and kind of integrate for actual weight, we actually did a local study in Buffalo because we had some discrepancies, and we oftentimes, as humans like to check a box. If we get information, we take it as truth. And also when you kind of related the EMS weight estimations to the hospital course, they were pretty spot on. But you even admitted though too that they might have taken EMS's estimations, and we incorporated something with a popper tape, which takes into account the body habitus of a kid. So you can basically use, and you do arm circumference, and you can kind of have a little bit of a slide and scale based on your findings to get a little bit more of an accurate weight. And the actual weight for healthy, non-acute, non-high acuity patients was then compared to a provider guess, and using the popper scale and then some type of length-based resuscitative scale. And the provider estimation without any of those tools was found to be grossly inaccurate. So that's just maybe something, and I could share those findings with you at some point too, just because it's interesting, because especially when you're dealing with
When I said they're taking the weight, the kids are weighed when they come to the ED, and the EMS providers are writing it into their chart.
Oh, okay, understood.
Because we can pull from the Epic writes whether or not it was an actual or stated. It's always an actual, because our EDs have regulations that every patient 18 and under must be weighed as part of their initial vital signs, on a scale. So it's not ideal body weight, but it's total body weight. I think the thing is it lead to clinically significant error? So we have one that's technically an error on Versed dosing, where it was 0.75 of the actual dose, and it's because it was a 1-year-old that weighed 13 kilograms, and they used an estimate of a 1-year-old weighing 10 kilograms, and it's 0.75. And I would say, that does not keep me up at night, right? Like you're close to the ballpark. 5-fold overdoses, or children getting 25% of the correct Versed dose for their seizure and only getting redosed 5 minutes later, that keeps me up at night.
Definitely, understood. Well,
Yeah.
and taking math out of the equation, that pesky little decimal point, you don't want to give 10 times or 1/10 of a medication, because that's not going to be therapeutic, right? So, no, I think that's great work. Thank you for sharing.
Any other comments?
Yes. So I did just want to address the medication calculation that Ben just brought up in the Muru app, because I have been able to calculate medications in the Muru app. And we actually, Steve Blocker is here. He came early for meetings, so if nobody minds, he can talk to the specifics of that, because I used it, but he knows how it works. So if you want to just come up real quick and explain how that works for, maybe, you're not the only one that has experienced that.
I feel pretty strongly with my ability to do math, but yeah, thank you.
Hi, Stephen Blocker, CEO of Muru. So just to answer, first of all, this study is amazing. So rarely do we get to see anyone admit document a baseline to then watch the improvements. So thank you for all that incredible work. To answer your question about pediatric dosing, so about 25% of all the doses done in Muru are for pediatrics. They also use it mainly for adult pain management and other things like that as well. But the way we have them do it is rather than focusing on pediatrics. When they either go into Dose Builder, they select an age, but in reality, just with search, they can say, I have a 7-year-old, and it knows that 15 years old is the cutoff in New York, and then automatically starts calculating for pediatrics. So if they say anything from barking cough for a kid, it'll know, right? We're going to a protocol that covers croup all the way through. So the pediatric dosing is in there too for that purpose. And as far as the adaptability that was brought up before, with regards to kind of weight-based dosing, I totally agree, right? If it's not all in one place, it's incredibly hard to get people to remember which app to pick up for what thing. And it does need to really be incorporated.
Thank you.
Well, I want to thank everybody for their questions and comments, and I want to thank Dr. Dorsett for, an incredible presentation and for fielding these sometimes difficult questions with aplomb and, and in detail. So thank you, Dr. Dorsett, and we hope we continue to see you here all the time.
Thank you.
If I might add one last comment to the discussion here before we move on. I was part of the initial group that developed the initial set of pediatric protocols back, in the 1300s. The truth of the matter is that, as we all know, nobody ever dies from the XYZs. They only ever die from the ABCs. Building off Ben Casper's comment a little bit earlier, that we are flooded with apps and sitting there on our handhelds, calculating this, that, and the other thing, sometimes, can take away from, the fundamental care that we're providing the patient. And when we did design those protocols back in the day, we designed them according to a model that we referred to as conservative yet permissive. Conservative in the sense that the emphasis was always on basic life support, because that's the XYZs as opposed to or the ABCs as opposed to the XYZs, and to cite the example that we've utilized so frequently in the last half hour or so, the seizing child, okay? Making sure that we maintain good ventilation is, really the start, and maybe not necessarily finish, but pretty darn close to the finish as well. I also want to, point out that for the great majority of drugs that we use in the pre-hospital environment, the therapeutic to toxic ratio is pretty wide, and that's especially true, in the pediatric age group. It's not to say that, as you were pointing out, Ben, that a 5 times greater dose or a 1/10 dose isn't optimal. And in some cases, it's going to be, seriously problematic. But in most cases, even if the drug dose is off a little bit, it pales in comparison to, making sure that the support of airway, breathing, and circulation, is not being properly attended to. So this is, I want to point out, that as always in the kind of work that we do in critical care environments, including EMS, we tend to focus on the itty bitty details, at the sort of the end of the rainbow in terms of the level of support that those medications are providing. And as we all know, it's really the ABCs that are really the part and parcel of everything we do, not just in the field, but also the emergency department and in the ICU. So while this work is really important, we want to make sure that the medication doses are as close to exact as we possibly can. At the same time, we want to ensure that we're not neglecting the basics, and I think that it's incumbent upon all of us to ensure in our educational programs and quality improvement programs that the major focus remains, where it belongs, on support of ventilation, oxygenation, and perfusion while we get the kid to the hospital. So that's my little soapbox editorial. Forgive me. But I can't help it. I'm a dinosaur, and there we are. So we can do that, and particularly because Megan Williams is in the room. So we are going to jump ahead at Amy's excellent suggestion to hear from Megan Williams about the length-based resuscitation tape review project that has been led by our colleague Megan Williams from Borough of Manhattan Community College in New York City. Megan, take it away.
Absolutely. Thank you. And the presentation that Dr. Dorsett did absolutely tags right into this. And it's kind of the furthering along of this particular project where the paramedic students really compared multiple different resuscitation tape devices along with hand heavy. They had not yet implemented MURU as well into this, but it comes kind of a moot point in comparing the New York State protocols and medications, medication dosages. It becomes a moot point when you talk about apps because they just upload what you want them to upload. So there's no gap to analyze between MURU or hand heavy. As alluded, the cost is usually the factor when we're talking about the different apps. So in particular, this document really compared we did 3 different resuscitation tapes. And I think the takeaways, you can read through the charts, you can read through the gap that we analyzed and really highlighted the gaps that we saw between each one of these tapes. But the overarching that we ended up seeing was that the apps have the exact information. There is no gap. And the other big thing that we saw was that there's a very big difference between resuscitation tapes that are focusing on literally resuscitation and excluding the other medications that you would give during an emergency. So that seemed to be the largest gap when we were talking about resuscitation tapes. They are focused on resuscitation. And as you look through this document and you look at the different resuscitation tapes as opposed to the apps, there are a large amount of medications that are just not on those tapes. So they might be cheaper overall as we're looking to fill the gap of the medication errors and also what is out there for providers to use. They're missing a lot of medications, and it really comes down to they're focused on resuscitation. And we've expanded from 20, 30, 40 years ago on the amount of medications that we give, and certainly in the pediatric realm. So resuscitation tapes are doing resuscitation and creating a very large gap in the rest of the drugs and forcing a lot of math, which we've talked about a lot and no one likes to do, especially in the stressful situations. So closing that gap is a big thing. We talked last time in February about whether or not the providers had more difficulty or were taking longer to implement an app versus the actual paper or just straight up memorizing. And like Dr. Dorsett also said, our students and our newer providers, technology is everything. So the biggest gap into implementation was really the instructors and the evaluators learning that when they didn't have an app when they first started. The students, on the other hand, yeah, they were teaching us a lot of the time because it's just intuitive for them. We saw that they had much more time delays and much more of a problem not implementing an app and not relying on that. Obviously, we trained them in proper technology etiquette, so not just sitting there and ignoring the person, not having eye contact, and just getting on their phone and the person, the patient, being able to assume, well, they're just taking a picture, or they're not interested, or they're checking their email, or making dinner plans. We obviously address that very quickly into proper etiquette to make sure that it doesn't cause more stress into the situation. So we saw a lot with this gap analysis really just highlighting the basics, that the resuscitation tapes are exactly that. They're resuscitation, and we've expanded exponentially into the amount of medications that we can give, and there's a large gap there. And as Dr. Dorsett said again, it's expensive. So we did look at hand heavy. The cost for each one of these is listed on the 3 devices that we did look at, whether or not it was the paper tapes or physical tapes or the apps. So all of the prices are listed towards the end. And hand heavy tends to be very expensive, as everyone talks about. Muru is another good option as far as coming along and giving or filling the gap here with medications, and significantly cheaper, if not free, in some of these aspects. So I think that this gap analysis really highlighted what are we doing with medications and where have we come from and gone to, and what are the expectations. And it dovetails perfectly into Dr. Dorsett's research and implementation as well.
Thank you, Megan. Where do you think you're going from here in terms of this project?
I'm certainly looking at implementation over the next couple of months with both Muru and hand heavy into our paramedic students, and then into the fall semester with new paramedic students starting and hitting the ground running. I think the original question that caused this analysis to begin with was whether or not the protocols matched, or whether or not the protocols had an adjunct to make sure that the providers were able to give the best care possible. This really just highlights that we don't have one particular system. And I know in the last meeting, we were talking about maybe having a document that was a quick, down and dirty, one-page document for people to reference. That could be an option as well. But whether it's Dr. Dorsett's or this particular project, it really does highlight that there is a gap here that we need to fill in some way, shape, or form.
I guess what I would wish for the children of New York State is that you and Maya could get together and sort of dovetail your efforts so that, we can, if you will, come up with a process by which we could identify sort of some kind of reasonable, middle ground kind of solution that could be broadly applicable throughout New York State. Because that's really what we need. As has been pointed out, we have multiple systems, multiple tapes, multiple apps, and all of them, while, shall we say, very similar in their content, all have some little, differences around the edges. Those differences may not always be, of a clinically serious nature, but as we all know, our paramedic colleagues, are kind of caught betwixt and between when there are, multiple, different approaches to the same problem. Those of us who've been involved in this process for a while probably recognize to some extent when there are multiple different solutions to the same problem that we don't really know what the correct answer is, and we have to, come up with, our best educated guess as a community of experts as to, how to solve this problem. So again, I would ask that for our next meeting, you and Maya get together and think about what we could potentially do. I mean, it might, not meaning in the anti-American way to foreclose any competition between groups of vendors that all of whom are doing their best to put out excellent products. But I'm thinking of something along the lines of the triage, algorithms that are out there, where our dear friend and colleague, dearly departed, Brooke Lerner, God rest her soul, led a project called MUCK, which is a document that ultimately said, if you're going to, have a triage, algorithm, that it needs to meet these particular requirements, and if you will, a set of, generic standards that need to be met. And perhaps something along those lines is something that you and Maya could come up with and bring back to the committee in the fall. I think that would be, I recognize that would be a lot of work, but at the same time, I think there's a lot of value in pursuing an approach like that, because we really do owe it to our paramedic colleagues to make sure that we are able to make a scientifically informed recommendation as to what approach should best be taken. So, thank you, as always, for all your hard work, and we look forward to hearing from you again soon.
My absolute pleasure. And I think that you're right on when you talk about a minimum standard being set, because this can be met with a large number of different applications or just physical guidelines. I think we would also be remiss, and I'll speak to Maya about this as well, if we didn't use the resources that are also available. So in order to look at how many people in the state are already using apps, and just using whether it's hands heavy or how many users are actually on Muru, that's going to inform us as to where to really go with this, because if we're looking at it and going 65% are on hands heavy or 75% are on Muru, we can make any recommendation we want, but that would be very illogical to ask people to move or switch when it's already being done. So we'll take a look at that as well.
It reminds me, of course, the discussion that was taking place regarding technology 150 years ago that has got us all stuck with a QWERTY keyboard on our computers. We, to a certain extent, the marketplace does end up setting the standard, but it would be very helpful, I think, to our marketplace if we did provide them with some guidance that's scientifically evidence-based, and look forward to your movement in that regard. So thank you.
Mr. Chair?
Sir.
So I just want to point out something that I think is fairly new, and please, by all means, feel free to correct me. I know you have the historical side of it too, but the work that Megan, hold on before you go. The work that Megan and her students did is one of the first collaboratives that I've seen where there was an ask of a state council to look into something, and that the initiative was actually picked up by a body of students, paramedic students in this case, to look into something and then come back and provide a report and some information from that. And I just think that that's a pretty incredible new kind of way of approaching it for us, both engaging our paramedic students who are the future of EMS, as well as having a need of something to be looked at. We often look and say, well, there's plenty of things we'd like to look at, but we don't have the time or the bandwidth to do it. So I would just like to recognize also Megan, her team, and the initiative of taking an alternative pathway to look into this and research it, because I think that's pretty amazing, and really appreciate everything that you've done and your students particularly.
Greatly appreciated for that too. And to be honest, I did it to serve two purposes. One, it definitely benefited their education. And two, I didn't have a lot of time, so they certainly were able to help with that, to say the least. But I will say, just to add on to what you're saying and emphasize what you're saying, the small amount of additional time in putting together the rubric and the homework assignment paid off tremendously. I have very passionate, interactive students, and they weren't necessarily like that before on this particular topic. They grumbled a whole heck of a lot on the extra work that they were doing, but now they're really invested, and they're really invested in getting down to the minutia and asking the questions of, but why? And why can't we do this? And that is really exciting going forward, because I haven't seen that level of engagement and involvement in the past 15 years of running paramedic programs. And they are also participating and informed, not only on their county level, but on the state level. So I'm getting a lot of questions, whether it's positive or negative, with them saying, well, I heard from going to the state meetings that we're not going to have a practical skills exam anymore. Can you tell me? And I'm like, no, good, but roll it back a second. So it is very exciting about what they can potentially do towards the future, and they're looking into how to get more involved, which is very exciting, because we need more people doing more things.
How many students participated in this?
16.
Would you be able to give us a list of names of who
Sure.
they were?
I know them.
Thank you.
Welcome.
Yes, we all have had an opportunity over the years to interface with our paramedics, who always somehow find a way to ask us the tough questions that we hadn't necessarily thought of the answers to. And the fact that, and thanks to Ryan and for pointing this out, and Megan for taking the lead on this, our students are often, the best people to present a solution to a long-standing problem, since, as we all know, engaging the front line and solving any problem often turns out to be the best approach, and unfortunately often the least followed approach. So thank you all who have thought about this and will continue to think about it. And again, Ryan, thanks for your comments, and Megan, thanks for your work. Okay, good. Sharon Shimento, it is time to talk about our favorite subject, for which Dr. Von Riat has almost single-handedly assured us that no drugs will ever be needed, because we're going to be doing everything by de-escalation. Let's hear about the Pediatric Agitation Project. Thank you.
Well, the work group has been very busy in the last couple of months. We've actually started to develop the scenarios that we've been talking about doing. They've finally gotten some work done on it. Megan has done a great job on one, as well as Vera Foyer. So the two of them have developed their scenarios. I sent them all out. I believe everybody here should have received it an email last week from me. With the scenarios in them so that you can take a look and see. We would like any comments, if anybody has any comments about the current drafts of the scenarios, so that we can go the next step and actually start to get some of the videoing done. So my goal would be if anybody has any comments, if they can send them to me by, let's say, Friday of this week. Then I can get everything over to Chief Pataki, and he can start to work on the storyboards or wherever else he needs to do. The one issue is that the third case, the one on autism, Mark Filippi was in charge of. He is now going to have to withdraw from working on that case. He's gotten too busy with his job. He did send a PowerPoint of kind of the teaching points that we would want to include in the scenario that he developed with his son, who works with children with special needs. So we would look to now to find another person to write that particular scenario. And Megan actually, yeah, she's coming up. I'll let her make her suggestion. Go ahead, sir.
Please, Megan, go ahead.
I have worked with Sarah Gerver in the past, and she definitely presented last year at the Vital Signs Conference and has some really good knowledge on autism as well, so she might be a great resource to tap into for that.
Okay, so.
Thank you. That would be great.
Okay, great. Yeah, that would be great, because that would be the second goal then, is to get that scenario developed in the next couple of weeks, maybe hopefully by let's say the end of June. From there, our time frame is to get everything started to be put together so that at our September meeting, we would have to have everything in by July 22nd in order to have everything available to put up on the screens at our September EMS-C meeting. And then hopefully, if any final edits could then be done by mid-October for approval December meeting, and then hopefully roll out the beginning of 2025. So that's kind of our goals going forward. I think the scenarios are really very well done, and yes, I see your card there. That's the other thing, yes. I absolutely would like to use some of that information for the PowerPoint that goes along with it, as well as handouts when we do this particular scenario rollouts. So that is excellent. Also, I think a lot of the points, both in Mark's development, we can put into, because we're going to need to develop the slides that go before, after, in between the scenarios as well. So the information on that, the information on the information that Mark sent, as well as the previous PowerPoint that Fidney had done, I think we should be able to come together with some kind of a flow of slides to go in between the slide sets, as well as perhaps some toolkit kinds of materials as well. I see.
Thank you, Sharon. So I spoke with Captain Randy Lee from the FDNY AV unit, and he's so graciously donated his time to help us produce these videos when the time comes. And he's given a time frame per scenario, at worst case, about 4 weeks per scenario to shoot, edit, and have a product for us. So by our next meeting, we should have at least 2 videos ready. We're hoping to make that July deadline so we can actually show clips of it. And he's assured me that he can actually put together kind of a brief synopsis for this committee, and we might be able to show that at the next meeting. So we're hopeful for that, but I just want to recognize Captain Lee for his time that he's been donating to get these videos produced.
Thank you, Chief.
Yes.
Dr. Vondergat?
Thanks very much, Sharon, for heading this group here. I did have a chance to look at what you sent out, and one thing that is kind of a big thing for that child with autism, if there's a way to incorporate the importance of the caregiver, whether it's a teacher or whether it's a parent, in terms of the EMS provider really using that as a resource, how to handle that child, I think that's really, really important. I handle these kids all the time, and we are totally dependent on how the family understands how this child might best respond. So I think that might be a really good educational piece for the EMS provider. That would be, even if it's a phone call, away if the parent isn't there. So.
Thank you, Elise. I might also add that recently was exposed to a group in New Jersey known as JOYDEW, Joydew, that does a boatload of work in the autism spectrum space, and a lot of work with public education and so on. It might be worthwhile, checking out their website and contacting them to see if there's any help that they could provide or information they could provide. I think it would be, very useful as we, finalize the development of these scenarios. As good as the scripts are at this point, and our plans for the immediate future. JOYDEW, Joydew. Joydew.org or com, I've forgotten which. Okay, thank you. It should be pretty easy to find. Thank you. Any other, yes, Ben?
Yeah. I just wanted to second Dr. Vanderjet's comments as far as incorporating the family members or just anybody that's able to provide supportive services for any agitated patient or anybody that has autism, mainly those that have autism, like the paraprofessionals, the teachers, if it's in a school-like setting, and also when it comes to the agitated patient or the child possibly with autism, to either exclude certain people from maybe that might be triggering that particular event. But I do think that the environment plays a pivotal role and how that all plays out, just from my own personal experience, because then you can de-escalate situations a lot better when you don't have that triggering factor present. So, thanks.
That's a great point, Ben. Thank you. And it just sort of a light bulb went off in my aging head. As you point out, the school environment is an incredibly important environment for us, those of us who deal with kids, that we don't often talk about in terms of our interface, with the EMS system and so forth. I wonder, Amy, if it would be worthwhile to reach out to the Department of Education and see if there might be some level of interest. We did reach out to our colleagues with the crisis stabilization centers that we spoke of last meeting, and it might be worthwhile to get some of the folks from SED, aware of what we're doing as well. I'm sure that they have already begun to develop some programs and so forth. And it would be important for us to know about them at the very least, so that if there is anything that we can learn from them and vice versa, we could potentially include some information in the in the scenarios that are being developed about how to deal with the situation when the child is in school or what have you. I leave that to folks who are far more expert in this area than I am, just to say I'm not an expert at all. And, I think that, but I think as many people that deal with this problem on a regular basis that we can interface with, I think would be to the benefit of all. Thank you. Dr. Vanderjagt has another comment.
Since we're talking about resources, it just dawned on me, Sharon, you should contact Lynn Cole, C-O-L-E. She is the clinical director of the Department of Developmental Disabilities and Pediatrics. as well as a clinical director of the Center for Autism Spectrum Disorders at Stratton in Rochester. And I think that a person like that really would be very helpful in looking at the scenario and seeing whether it makes sense, because they deal with these kids all the time. That's where they go for at least our entire region. So.
Thank you. Sharon?
Dr. Van Der, could you send me that contact information? Thank you.
Any other comments? Okay, well, hearing none. It is time to hear from Dr. Van Der again about the procedural sedation work group. Elise?
We have not met, I have to say that. I think Amy was really kind enough to send up a survey and asking whether people would be willing to meet with this. But there was only one response to that. So I don't know whether this is something that is not of interest. If there is, I would love to move forward with that. And for those who are volunteering, I think just a person, I think you were the only one from Syracuse that presented. And you would, okay, so you would like to be part of that too. I will unearth that because I really do think that procedural sedation in the emergency department is really, really important, especially in the community hospital areas where there may be less expertise in dealing with procedures in pediatrics. So this is a national issue. And in fact, I should say that this has become now also again, moving in the sedation circles nationally, it's become an international issue of how to manage short procedures in EDs that are very painful, that are very scary, and how do you do this? So I think that this is a wonderful conjunction of EMS-C under the umbrella of what EMS-C means, which is the entire spectrum from EMS to ED to ICU and all the way through. I think this is a really important piece of it. So yes, I will, Dr. Ford, okay, as well. And if there's anyone else, I will reorganize it. Oh, there you go. We'll do that too. Thank you.
Okay, so Dr. Pamela Foyer and Nicolo Toole, that group with Dr. Van Der, yes. Okay, so we'll look forward to a discussion over the summer and, you know, an update in the fall. Thank you, Elise. So the next item on the agenda is officer elections, and I'll ask Amy if she would, you know, update us as to where we are with that.
Sure. So there were some questions that were brought up about how do officer elections work, when does that happen, those kinds of things. So I did speak with our lawyer, Wahija, who was great and reviewed the documents, and also much thanks to Steve DeZura. So we looked at the public health law, which doesn't say a lot. It only says that the chair of the committee is appointed by the commissioner. And then in looking at our bylaws, a majority election. So essentially, when that election comes up, whoever is putting their hat in the ring, whoever gets the most votes, then that person would be submitted to the commissioner for the commissioner to appoint the chair. And so according to the documents, that happens every 4 years on the revetting of the chair. So Dr. Cooper's revetting letter is sitting in process. It's on its way. So once that letter is approved, it will get sent to Dr. Cooper, and then, so I hope they approve it before the next meeting, because I have been waiting a little bit. But once that is done and he is officially reappointed to the committee, then we can start the process for elections. And whoever is interested can say they're interested, and then we'll have a vote at the meeting.
Thank you. I'll just take the opportunity to say that I would be more than honored to continue as chair for one last term, if that is your wish. But of course, this is a democracy, and anyone else who wishes to serve as chair, should by all means, not hold their peace.
I forgot to mention one thing, I'm sorry, Dr. Cooper. The chair has to be a physician, according to our bylaws. So for those of you who are interested, it would have to be a physician to be the chair.
It was also decided at a previous meeting years ago that the vice chair would also have to be a physician because he or she would need to be able to step up into the president's role.
All that having been said, we all need to remember that the law is quite specific, that the commissioner does appoint the chair, and he or she could appoint whoever he or she felt was the most qualified person to assume that role, regardless of what, advice this committee, put forward. But that is the, shall we say, the process that's followed for virtually all advisory councils under state government. It's usually a commissioner appointee and, or gubernatorial even, in the case of certain advisory councils. But the commissioners in the past have been very gracious in accepting our recommendations to going forward. Thank you. Okay, any questions about that? All right, well, hearing none, let's move on to our updates from our, our partners in support of emergency medical services for children, and begin with the report from Aldo Sanaga or Linda Efren from the Quality and Safety Sepsis Initiative. And yes?
I have their report.
Yes.
Okay, please.
So they could not be here today, so George emailed me some of the updates. So I will read them to you. So the New York State Department of Health sepsis team will be presenting the results of the sepsis protocol and training requirements HERD survey that was completed last fall on June 5th, 2024 via statewide webinar to be hosted, and it will be on their announcements page, and their webinar link will be posted there in advance of the meeting. So the survey was administered to assess how hospitals across New York State that report sepsis data are currently implementing sepsis protocols and sepsis training requirements in accordance with Title 10 Health of the New York State Codes, Rules, and Regulations, Sections 405.2 and 405.4. The regulations have specific protocol requirements for infants and children, and we will be reviewing aggregate results from hospitals across the state and sharing key takeaways. They also mention that the sepsis team has continued to plan for the release of the 2021 Sepsis Public Report. The report will be released in a dashboard format with previously unavailable features to allow users to interact with the data. The report is not yet available, but will be hosted on the New York State Department of Health Sepsis webpage when approved. As stated in previous updates for our committee, the New York State Department of Health sepsis team will be happy to provide a more thorough update to the committee once the report is public.
Thank you, Amy, and please express our thanks to George Sadidis, who is assisting Drs. Osanaga and Efren and in this arena. I do think that we should impress upon our colleagues in the quality and safety, area how important it is to this committee that they be here in person to provide a report. I think we all recognize that that sepsis has become, a leading cause of death in New York State's children. Probably second only to trauma, and something that needs to be, made exquisitely aware to this particular group. Recognizing the signs of sepsis in the field remains a challenge. for our colleagues in EMS, but also in many emergency departments where the volume of patients with, pediatric sepsis can be pretty low, and therefore the experience in identifying sepsis in its early stages, not always as good as we might like. So the help of our colleagues in the Division of Quality and Patient Safety will be very, very important as we, think about how to really assist our EMS providers in getting the recognition done as quickly and accurately as possible. So thank you. Elise, please.
Yeah, as you know, I've been very involved in sepsis. I'm on this committee, actually, but I just wanted you to know is that the World Health Organization has put out some statements about this. There's been a recent, as you know, World Health Organization International Day of Sepsis in this past few weeks, and I just crossed some data across on their website is that almost half of all estimated sepsis cases worldwide occurred in children under 5 years of age. So this is truly a pediatric problem, as you say, Dr. Cooper. This is something that we need to be very involved with, and I think this is important.
Thank you, Dr. Vandia. And of course, I would be remiss if I didn't acknowledge Dr. Conway's contributions to the international efforts in recognition and management of pediatric sepsis. So Ed has been a real stalwart in that area and member of the committee that helped devise our national protocols. And Ed, I'd invite you to add anything you might want to add at this point if you have anything to say. Don't feel as though you do if you don't want to, but that's fine. Thank you. Okay, now we move on to our colleagues Susan Stegich and Kate Alfonso from what is affectionately known as BOHIP, the Bureau of Occupational Health and Injury Prevention from the department to tell us about current injury prevention activities.
Thanks so much. All right, a few updates that we have for pedestrian safety. We're continuing our pedestrian safety campaign media buy. The Department of Health ran a visibility in winter campaign as well as a distractions campaign in April. And so our goal is to raise awareness and reduce pedestrian-related risks through education and outreach on pedestrian-related vehicle and traffic law. We're continuing to develop new tip cards to raise awareness on the understanding of traffic control devices at crosswalks and how to use those devices for crossing safely. We're also conducting 3 focus groups, one of which we just finished conducting in Albany, Rochester, and Yonkers to learn more about what community members believe are barriers to vulnerable road user safety. And we define a vulnerable road user as a pedestrian, bicyclist, person using an e-bike or an e-scooter or other rollers. And this also includes pedestrians working in work zones. We did just finish our first focus group that was in Albany, and it was at Albany High School. So we spoke to kids that go to Albany High School to see what some of their concerns were as it related to pedestrian safety and what we could do to help them in that area. For child passenger safety, we have a CPS pictorial video that we're producing that's going to illustrate car seat installation instructions for limited English-speaking and reading populations, so it's going to be very picture-focused. Additionally, we have a counterfeit car seats publication that we're collaborating on with different subject matter experts, and it's going to be focused on the dangers of using counterfeit car seats. We're also going to be holding a Safe Travels for All Children, or STAC, training June 19th and 20th at the Helen Hayes Hospital in Rockland County. For motorcycle safety, we are collaborating with Columbia University, the Governor's Traffic Safety Committee, and the Motorcycle Safety Foundation to join the Seneca Tribal Nation at their community fairs, and we conducted a motorcycle helmet fitting and shared our safety publications at those fairs. In terms of micromobility, we're going to be collaborating with the Bureau of EMS and Trauma Systems, thank you to Amy, to develop a micromobility tip card focusing on e-bikes and e-scooters, and we just intend to bring some familiarity to the topic for folks in EMS. For younger driver safety, the Driver Education Research and Innovation Center, also known as DEREC, the first of 3 workshops for DEREC was held on April 20th in Rochester, and the training was conducted by members of the New York State Driver Training Safety Education Association, also known as NYSESIA. We have 2 more trainings that are being planned, one in the Albany area and one in Long Island. And lastly, the ACEs prevention through home visiting services publication. We're continuing to develop a questionnaire that is going to home visitors, home visitor programs, to get more information on their knowledge on domestic violence programs and to help reduce the number of ACEs in New York State. That's it for us.
Thank you so much. Any questions for our injury prevention colleagues? Okay, well, hearing none, it's now time to hear from our longstanding colleague, Marilyn Kasika, from the Division of Family Health. Thank you.
Thank you. So I'm going to give you some updates on a wide variety of topics that we've been working on. I think you may be aware in 2019, legislation was passed called Elijah's Law, and it dealt with anaphylaxis in child care facilities. So we worked with the Office of Child and Family Services for a policy to implement this law, which included guidelines on how to prevent, recognize, and respond to life-threatening anaphylactic reactions. So it was for the use of auto injectors within daycare facilities. So the policy was issued in 2020, and since then, they've gotten a couple questions about the policy that they had to do minor revisions. And one of the revisions of note was strengthening the language around calling 911 first rather than calling the parent first. So it's their automatic reaction to call the parent. So that's going to be strengthened. And also to add documentation of the time epinephrine was given, because EMS needs to know that. So we're going to strengthen that. And we did learn from them that this policy has had an impact, that on 3 separate occasions in 3 different daycares, the auto injectors had to be used. 2 were on children and 1 was on a staff person. So it's good to hear that they're actually using the policy. As far as infant safe sleep, I think I talked about this previously, but more than 120 infants die of either sleep-related causes or sudden infant death syndrome. So in this year's budget, the Office of Children and Family Services was given $2 million to work on infant mortality. And what they're going to do is work with facilities to distribute pack and play to families that are in need. And along with these pack and plays, there'll be a fitted sheet and safe sleep materials to be included. So that's being worked on now. We are working on the revision of the pediatric and obstetric toolkit. Amy's involved with that. We have subcommittees for each of the sections to review it. And I think, a lot of the things, Amy, you talked about today really dovetail with that toolkit as far as resources and getting them connected. So that work is ongoing. As far as early intervention, I thought I'd give you an update as far as the budget. There was a 5% rate increase for in-person services, which is one of the first rate increases in quite some time. There's a 4% rate modifier for rural areas and underserved communities for in-person services, and that will be implemented in fiscal year 2026. The methodology for that will be worked on in the meantime. They are eliminating back-to-back group services for a child on the same day. They're limiting the size of a group session to 6 children and limiting the number of children having a one-to-one aid in group session to 4. They're reimbursing teletherapy at the existing facility rates, and consecutive extended home visits on the same day for the same service would be prohibited. That was in the budget. The perinatal regionalization regulations are currently being worked on. We received 100 submissions and over 500 comments. So they're currently under review by the department. And after that, it'll be decided whether they need to go out again for comment or if, what needs to be done next. The other thing, we're beginning a New York State Perinatal Quality Collaborative NICU project on equity. We have one now that's focused on maternal outcomes as far as the Birth Equity Improvement Project, but this will be specific in NICUs. And it's really to look at the experience of care that parents will rate the experience of care through a survey when they're discharged. So sort of more qualitative things like, do you feel like you were treated fairly? Were you able to participate in the child's care, et cetera? As well as looking at policies and procedures within the NICU along equity and how individuals are treated. So currently we have 40 NICUs signed up and are looking for more. So, and I think as we were here, and you may already know this, the DOH advisory went out as with the proper use of automated external defibrillators in PEDS emergency care. So I'm sure you were all very instrumental in that. So that's out.
Thank you, Marilyn. That's unbelievable set of initiatives that you are working on at this particular point in time, and wow, you're busy.
We are busy, but it's good work and it's fun.
Yeah, absolutely. Any help we can provide, particularly with respect to the toolkit, would be, of course, freely offered and given. So let us know if there's anything you need from us from that standpoint. Okay. Or anything else. Okay. Good. Thank you. Questions for Dr. Kasika? Okay. Now it is time for Herr Professor Dr. Michael McAvoy to tell us about what's been going on at State Council.
Well, the State Council meets in 2 days, and we did not have a quorum in December for our physicians group, the CMAC. SEMSCO did meet then, and then we met again in February. A number of things, probably key things that are happening. One is in the February meeting, they approved what's been a 7-year process of sunsetting the EMT critical care level, and projected that will end around 2027 with a kind of a phased decline in it, accompanying the phased decline in the number of providers since we've allowed them to bridge into paramedic level care. And then we also approved 2 performance standards. Over the summer last year, we had several of the committees work on performance standards and submit a wish list to the State Council, and they approved a performance standard that would require agencies to conduct some quality improvement activities and monthly report those to the Bureau and to their REMSCOs. And the second performance standard that they approved was to track staffing and regularly report calls that are received, calls that are answered, calls that are turned over, and calls that are answered in other agencies' jurisdictions, which will give us some data on performance of the system. And both of those are sustainability standards, so the actual language of them needs to be worked out, and they'll end up in regulation, basically, at some point in the future. The other thing that did happen, which didn't occur at SEMSCO, but SEMSCO was very excited about all the things that were added into the governor's budget for EMS. None of those made it through, largely because the Assembly doesn't believe in passing legislation as part of the budget, and so they tend to veto everything that's legislative. However, if you look at the New York State Association of Counties website, there's a section on there called Rescuing EMS, and they list out 10 bills that are currently one-house bills, some of them with co-sponsors, that take all of the language that got deleted from the governor's budget and put it into separate bills. And so I would anticipate a significant number of those actually flying through before the end of the session in the next few weeks. So I think most of us feel relatively comfortable about that. And I think the reason why is there's very little opposition. There's a lot of agreement between EMS organizations, their associations, the Association of Counties, the Hospital Association of New York State, and even the nurses in a lot of those areas. So I think we'll see some movement on a number of those things. I think that's primarily the key things that are happening. There's a lot of work going on with the State Council subcommittees in between meetings, and most of them meet at least monthly, if not more often. And we'll probably have a whole bunch more news to give you at the next meeting after we meet in the next couple days, unless there's any questions.
Questions for Dr. McAvoy? Okay, well, hearing none. I apologize to you all for inadvertently skipping over a report from the Healthcare Emergency Preparedness Central Office Group. Deanna Radigan is here with us today to give that report, and we would love to hear from you. Thank you.
Thank you. Yeah, Kate wasn't able to be here today, so I'm stepping in for her. So just a couple.
We appreciate it.
A couple quick updates. We have the Hospital Preparedness Program Notice of Funding Opportunity, which is for the next year cooperative 5-year agreement. Is still pending. It was supposed to be to us in January, and then there was supposed to be the deadline of March, and we are still waiting. So once we receive that, any items that are pertinent to this group will be relaying to you, Amy, for that. As far as part of our current deliverables, the contract hospitals outside of New York City continue to complete the National Pediatric Readiness Assessment as part of their contract this year, and we've received the reports from the facilities. We've received 18 so far, and I know Kate has passed those on to you, Amy. So as we get those, we'll continue to send those along as well. And lastly, via the Capital District Regional Office, efforts to review and update the New York State Department of Health Pediatric and Obstetric Emergency Preparedness Tool are underway. There are folks that are sitting on committees that are reviewing this, different subject matter experts. So once that is completed, which the expected completion is spring of 2025, that will be going out revised and updated as well. That's it.
Thank you. Questions for Deanna?
I just wanted to make a point to say that the NPRP survey that is part of the HPP grant for hospitals outside of New York City is the same survey that you can use to join Always Ready for Children. So if you're already doing the HPP survey, it's the same survey. Please apply for Always Ready for Children because you've just done the bulk of the work.
Thank you, Amy. This is, an important bit of information, and for those of you who have have not urged your emergency department directors to participate in the Always Ready for Children program, please do so. It's really a very, very important program, and of course, Amy can help you. At least I hope she can now that she's doing both jobs until she finds someone to assist with EMS-C. But until that time, which we hope will take forever, please reach out to Amy for assistance in getting involved with that program. It's really so important. Thank you. Any other questions for Deanna? Okay, thank you, Deanna, and give our regards to Kate. Okay, thank you. Last but not least, the State Trauma Advisory Committee and Pediatric Trauma Subcommittee did meet earlier this year. Really, the major issue that was on the agenda was, in fact, the Always Ready for Children program. There was some discussion about the pediatric TQIP report as well, but most of the meeting focused on the Always Ready for Children program. And it was, as most of you are aware, or many of you are aware at least, those of us who are part of the trauma world realize that the new American College of Surgeons Gray Book standards do include a requirement that pediatric facilities participate in the National Pediatric Readiness Project, and of course, Always Ready for Children is a great way to do that. So bear in mind that that is a requirement now if you are a trauma center. So please make sure that the folks who work with you are, in the process of signing up for this program if they have not already done so. It's relatively painless, as many of these surveys go. It's a lot less painless than some others, or a lot more painless than some others, I should say. But it is really important that New York State have an opportunity to really review this data in terms of where we are, not just as individual facilities, but on a statewide basis. So please, please, please get your PEDS ED folks to really participate in this. And of course, those of you who are working with EMS agencies, please be sure that you're getting your EMS agencies to participate in the pre-hospital part of this project as well. STAC will be meeting at the end of this month. Work, of course, remains ongoing in terms of getting everybody, verified by the college. And all of our pediatric trauma centers statewide are in various stages of reapplication. The state regs, as you know, require us to be verified by the college in order to retain our trauma center designations, and we're all, actively pursuing that aspect of things across the state. So we have now completed the formal agenda. I do have one item of whether you want to call it new business or a special request from the chair. I think that, while we've done a lot of work today, covered a lot of ground, and we have a lot of really great projects that are ongoing, it's a never-ending, opportunity to raise the standards of healthcare for pediatric patients, particularly in the emergency arena. I do think that it's important for every single one of us to think about projects that this committee could take on, that, not shooting for the moon, but that are limited projects that are eminently doable, that, will take at least a reasonable sized bite at the apple, so that we can keep the wheels of progress turning. Most of the projects that we're focusing on at the present time, bubbled up in that exact way. So for those of you that have, special, interests or special thoughts about projects that this committee could undertake, particularly as Ryan and Amy have been able to identify some, potential research slash statistical support for the, for the program, I think will be very, very important, very useful. So I urge you to think about that. Please feel free to share any thoughts you may have in that regard with me, Dr. Vondriat, and of course Amy and Ryan. It's really important that we keep this going. As so often said, children, although they may represent only 25% of the population, are 100% of our future. And if we're to have a healthy future, it has to begin with healthy children. So please put your thinking caps on, and let's see if we can come up with some new ideas for the immediate future, and that will be a great thing if we can think about additional projects to focus on as a committee that will improve the lives of children across New York State. So with that, any final comments from any member of the committee? Well, thank you all for your attendance. Hearing none. Amy, we are meeting again in September 16th. I presume we are here, correct?
We are
We are
going
not
to be
here.
in Saratoga, September 16th in Saratoga, and there is a time change, but.
Microphone.
I was telling Dr. Cooper so he could relay it. But, so it will be in Saratoga. I know that there was some difficulty finding a place large enough for all of us to meet. So we did find a place in Saratoga. I will relay that information as soon as all of that is confirmed, because I work with Teresa. So much thanks to Teresa, who handles CMAC and SEMSCO, for also helping with all the hotel stuff for EMS for Children, because we work together on it to make both of our lives easier. So once I have that, I will send out all of that information. Also, the time is changing for the meeting because they had one room that fit all of us. So we have to share Monday with the program agency meeting. So we will, which is currently going on now, which is why some of the people here have left. So here we can have an overlap because there's more rooms, but there's one room. So we have to share, and I will let you know the time difference as soon as all of that is confirmed.
Do you have a guesstimate as to what the time might be at this point?
From off the top of my head, I think we said 10 to 1 because their meeting is 2 to 5. And I recognize that some people like to drive in the morning, and I was not trying to make you wake up at 2 a.m. because I do that for the airlines, but I can sleep on the plane. You can't do that while you're driving on Route 90. So I recognize that some people do need to travel to get here. For those of you who do need to travel to get here, we will work on your travel information, and obviously all the same stuff that applies to coming here will apply for there.
And Ryan, I presume that we can expect that CMEC and SEMSCO will be meeting immediately thereafter, correct?
They are.
Thank you.
And actually, it will come up, it is not definitive yet, but it looks like that Thursday after will be the EMS Memorial, which had to be moved from May.
Thank you very much. That's very important information. And then finally, one other special thought for Amy and Ryan. It was stated earlier in this meeting that during EMS week, EMS-C Day is May 22nd. I realize time is short, but I wonder if there's anything special we could do to honor our program and its effect on, salutary effect on the children of New York State. Ryan, any thoughts?
So I do know that information has been passed along to the governor's office related to that, and we would have to wait to see what their next steps are related to it. So we will advise everybody if it is.
Okay, if indeed there is an opportunity for some kind of press event or something along those lines, I will certainly do my best to make myself available on that day, and perhaps Dr. Von der Yat might be able to join, to represent the children of New York State, and perhaps Nicole as our Family Advisor Committee Network representative. So we have the families represented as well. I think that would be a lovely moment, and it would provide an opportunity for the governor to, get this message out there in a very special way. So, Ryan, I guess the ball is in the governor's court. Perhaps you can lob the tennis ball again in her direction, letting her know that she'll have, some support in doing that event, should she choose to, make herself available. Thank you.
I appreciate it. I will relay the message.
Thank you. So that is it. We have completed our agenda for the day. I'm really surprised. I thought we were going to go over by at least a half an hour, given the content of the meeting. I just want to close. I like to close on a happy note, but on this particular issue, I think I'm going to have to close on a somewhat sadder note. We recently lost in New York State an incredibly great champion for children, Dr. Michael Frogel, originally from the Northwell Health System, but founder of the National Pediatric Disaster Coalition, who's worked extensively in the pediatric disaster space nationally, regionally, nationally, and worldwide for many, many years. He recently passed this about 2 or 3 weeks ago. He was an incredibly healthy guy until very, very close toward the end, when he sadly developed a rapidly progressive fatal malignancy, and we've lost a great champion for children, and I hope all of us will keep him and his family in their prayers. And rather than a moment of silence, I'll invite you all to have several moments of silence in his honor as you wind your way home. So thank you all so very much for coming today, and we look forward to seeing you on September 16th in Saratoga, perhaps from 10 to 1, perhaps at another time. But Amy or her soon-to-be colleague will be letting us know when that will take place.
And I will also, I apologize, and it should have come up earlier, Phil Malini, for those of you who knew the name also, was a program agency director out of the Arams region, a lot of a rural part of New York. He was a program agency director for 48 years, from 1975 till literally 2023, just last March. He did pass away last week, the week before, within the past 2 weeks. And they just had a very nice, as nice as it can be, service for him up where he's from. And so just his regards, and again, appreciation for amazing work over, nearly 50 years as a leader in one of the regions. And so just want to have you think about that one as well. Thanks, everyone. Thank you, Mr. Chair.
Thank you. So to return to that happier note, summer is coming. The sun is shining. All of our wonderful holiday spots in New York State, Lake George, the Finger Lakes, two big lakes, Lake Ontario, Lake Erie, all kinds of, Long Island, all kinds of wonderful places to spend time with your families and particularly your kids. And may you all have a restful, blessed summer, and we'll see you again in the fall. Thank you all for coming. Motion for adjournment? Yes, thank you, Dr. Von Diat, Dr. McAvoy, I think. All in favor? Aye. Opposed? Thank you. We'll see you in the fall.